Hello, and welcome to this training presented by the Leukemia and Lymphoma Society of Canada, Mantle Cell Lymphoma from Diagnosis to Treatment, Supporting Nurses. My name is Natasha Sani, and I'm the Community Service Lead for the BC Yukon region at the Leukemia and Lymphoma Society of Canada. Before we begin our main presentation, I would like to share with you our mission and present some resources that may be helpful to you and the people you support. At the LSC, our mission is to cure blood cancers and improve the quality of life of those touched by blood cancer and their families. We listen attentively and with compassion to the challenges our community is facing, pointing them to the information specific to the type of blood cancer or treatment. We help them get organized to manage and take charge of their care, and we can identify services that would be beneficial for them. Please visit bloodcancers.ca to find the contact information of the community service lead in your area. We offer a continuing education program that you can join free of charge. You can register to one or more trainings that you can do at your own pace and receive an electronic certificate of participation. They are all offered by experts. More than 1,500 healthcare professionals are using the platform, and there are 40 trainings available. These are available for you, training on blood cancer, treatments, psychosocial aspects of cancer, and more. We are continually adding to our training roster. Also available online are all of our educational tools and resources. These are vetted by experts for all the main types of blood cancer, treatments, secondary effects, and more. Our material is available in multimedia formats to address the variety of needs and preferences. They include digital disease booklets, fact sheets, podcast episodes, animated videos, and webcast recordings. By visiting our website, you can place an order for materials that will be sent directly to your cancer center or clinic. Materials that can be ordered include disease booklets, service posters, palm cards, and much more. All these tools can be ordered or downloaded through our website. You can order our therapies for easy reference to our services, or blood cancer literature to inform those affected and the families you support. It is all easy to do and free of charge. Most of our educational materials can also be downloaded through our website. With this handy electronic form, you can order materials to be shipped directly to your location. It just takes a few clicks. If you have any questions, please reach out to the community service lead in your region, and we're always happy to help. Emotional and practical support is a priority for the LSC. Our peer support program has been identified as a key service, but many don't know about it. Trained volunteer survivors who are 1 year post-treatment share their stories with newly diagnosed patients or those facing a new treatment option. Age, gender, diagnosis, and treatment are considered to ensure the best possible match. This program helps to build hope, it alleviates anxiety, and creates realistic expectations. We also offer professionally facilitated virtual support groups. These support groups are offered coast to coast and gives the opportunity to the blood cancer community to connect with others who are facing the same challenges from the comfort of their own home. Each participant builds connection through group discussion, sharing coping methods, information, and helping break isolation. Please visit our website, www.bloodcancers.ca, or reach out to the community service lead in your region for more information. It is now time to introduce our speaker today, Dr. Diego Villa. Dr. Villa is a medical oncologist at the BC Cancer Centre in Vancouver and clinical associate professor at the University of British Columbia. In addition to attending to patients with lymphomas and breast cancer, he also teaches trainees and conducts research in B-cell non-Hodgkin lymphomas. His main research interests include mantle cell lymphoma, primary and secondary central nervous system lymphomas, and the role of PET and CT in lymphoid malignancies. He presently leads national prospective trials of novel therapies in aggressive lymphomas. Over the years, he has collaborated with several international groups on NHL studies with over 100 publications in the peer-reviewed literature. Dr. Villa is also a lymphoma co-chair with the Canadian Cancer Trials Group. Over to you, Dr. Villa.
Hello, everyone, and thank you very much for inviting me to speak about one of my favorite topics, which is mantle cell lymphoma. And today I will give you an update on diagnosis and treatment of this condition. This is going to be our outline for today. We'll first begin with some background on the biology of mantle cell lymphoma. Then we'll talk about frontline therapy and how it differs depending on age. And then we'll finish with a discussion of therapy for relapsed or refractory disease. Before we get started, I would like to just go over some terminology, just so we're all on the same page, as I will be using these terms as we go along. The first term that I think is important for everybody to understand is response rates. So here I'm showing a CT scan of a person who has a large mass in their mediastinum or their anterior chest. And you can see how you can measure this mass at about 17 centimeters. And let's just say that this is kind of the overall size of the mass. This person's going to get treatment, and this mass will either shrink or it will not respond to treatment. If the mass disappears or measures less than 1.5 centimeters at the end of treatment, we call that a complete response. If the mass shrinks but it doesn't completely disappear, we call that a partial response. And collectively, we know both of those as overall response rates. So typically one reports the overall response rate, and then you further describe that by mentioning the complete response rate. If the mass doesn't change, we call that stable disease. And if the mass grows or if there are no lesions, we call that progressive disease. The other important point that I think is important for people to be familiar with is survival analysis. And so these are curves that I'm sure many of you have seen before. These are called Kaplan-Meier curves. And what they do is they tell us how a group of people do over time. So the way this works is you always plot time in the x-axis and you plot the probability of event in the y-axis. And so in the example in the left, progression-free survival, which is typically disease progression or death, at time equals 0 when you start a treatment is always 100%. Why? Because everybody is progression-free. Similarly, on the right, we're looking at overall survival. At time equals 0, it's always 100% because nobody has died yet. You roll out your treatment, time goes by and people are going to die and or their disease is going to progress. So in the ideal world, you want a horizontal curve. In other words, no progression events and no deaths with time. Now, we know that's not going to happen because people die all the time or people's diseases are not 100% sensitive to therapy, but that's what one ideally would like to see. But you can kind of see if you look at different treatments, you can begin to look at differences. So this is an example of comparing two regimens for mantle cell lymphoma in British Columbia. You have bendamustine rituximab in the blue line, and you have R-CHOP in the green line. You can see how patients treated with BR have better outcomes than those treated with R-CHOP. And so that just kind of gives you a visual of how patients might do with a particular therapy. So now moving on to mantle cell lymphoma. Well, how common is mantle cell lymphoma? We hear about it, but how common is it really? Well, it's kind of common. So it's about 6% of the non-Hodgkin's lymphomas that we see. Most of us in our day-to-day practice see diffuse large B-cell lymphoma and follicular lymphoma, and that's because they're very common. But I'm sure everyone here sees other lymphomas such as chronic lymphocytic lymphoma, leukemia, or multiple lymphomas, and those are about 7-8% each. What that ends up being is roughly 50 cases in British Columbia per year. For Canada, it ends up being about 400 cases per year. So the number is about one diagnosis for every 100,000 Canadians. So you could argue not that common, but not completely uncommon. The next thing is something that I see often and is spelling. So I think this is another important point for people to keep in mind. So a mantle, M-A-N-T-L-E, is a shell or the core or the core or the covering, sorry, not the core, the shell or the covering of something. So, you know, the earth, for example, has an outer and an inner mantle, and then you have the core inside. In the Victorian era, people would wear these kind of coats, and those were called mantle, T-L-E. Mantle, M-A-N-T-E-L, is kind of the shelf on top of a fireplace. So where does mantle cell lymphoma get its name from? From TLE or from TEL? It gets it from the former. So when you write mantle cell lymphoma, make sure you spell it with TLE. Mantle cell lymphoma is a lymphoma of the immune system. Where is the immune system? From head to toe. We have lymph nodes and we have lymphoid tissue everywhere because we need the the lymphoid tissue uh, processing antigens all over our body. There's also lymphoid tissue in organs such as the small bowel, the bone marrow, and many other parts of the body, and those can also become involved with lymphoma. So most patients, if not all patients with mantle cell lymphoma, typically have advanced stage, typically 3 or 4, because that reflects the nature of where the disease is coming from. The majority of patients with mantle cell lymphoma will have an involvement of lymph nodes. And so those were the structures that I was showing in the previous slide. So if you slice a lymph node and you look at the architecture of a lymph node, you will find that it has these structures called follicles, and this is where B cells grow, develop, and this is where B cells become able to recognize the different substances and bugs and toxins that come into our body. These structures are all surrounded by an outer mantle zone, as you can see it here. And so you can kind of see the analogy with the pictures that I showed a couple of slides ago. That's why it gets the name of mantle cell lymphoma. It's because it's arising in cells in this mantle zone that surrounds the lymph follicles where B cell maturation and development takes place. In other words, something happens to those lymphocytes in the mantle zone that makes them cancerous instead of normal lymphocytes. What does that look like under the microscope? It looks like a bunch of really abnormal lymph nodes with abnormal architecture and expanded mantle zones. So here you can see these nodules just totally effacing the normal architecture of the lymph node. You can still kind of make out the normal kind of follicles in the middle, but you can see how there's this kind of ring or this mantle of abnormal cells. And if you zoom into what these cells look like, then you got these B cells that are abnormal. And if you zoom into the nucleus of these cells, you notice that there is an abnormality with the way these cells go through their cell cycle. So think about it. Every single cell in our body is going through cell cycle. Why do your fingernails grow faster than your skin? Or why do you have to cut your hair every so often? It's because those cells are growing faster. Why do patients become neutropenic on chemotherapy? Because their neutrophils are growing quickly. The same doesn't happen with your liver. The same doesn't happen with the brain. Those tissues recover from injury a lot slower, and that's because they're cycling at a much slower pace through their cell cycle. And what determines whether a cell is growing and dividing versus not is a whole bunch of checkpoints, which I am showing here. And in mantle cell lymphoma, this particular checkpoint here between the M phase and the G1, in other words, right before that cell really takes off, is activated by a mutation that leads to overexpression of one of these proteins involved in the checkpoint. The net effect of that is that that cell keeps going at its own cell cycle. It's not resting, it's not quiescent, it's just going. And this is happening all over the lymphoid tissue where patients may have these abnormal mantle cells, including the bowel, including the marrow, spleen, and lymph nodes above and below the diaphragm. So patients with mantle cell lymphoma present with enlarged lymph nodes, splenomegaly, bone marrow involvement, and oftentimes with GI involvement. But okay, that's fine, but that's true of all lymphomas. So where does mantle cell lymphoma fit into all of the classification of B-cell lymphomas? So just to go back and take a kind of a bird's eye view of how we classify lymphomas. So we classify lymphomas into Hodgkin's and non-Hodgkin's lymphomas. And then we classify Hodgkin's lymphomas into B-cell and T or natural killer cell lymphomas. And then we further subclassify B-cell lymphomas by their behavior. So are they indolent and they grow slowly? Are they aggressive? They grow quickly, or are they highly aggressive and they grow very quickly? So you probably recognize a few names in that list. But some of you probably noticed by now, where is mantle cell lymphoma in here? And this is one of the features of mantle cell lymphoma. It's in the middle. Mantle cell lymphoma has a bit of an identity crisis because sometimes it behaves like an indolent lymphoma and sometimes it behaves like an aggressive lymphoma, depending, and it changes from person to person, depending on the type of mutations that that cancer has. It has really the worst of both worlds in the sense that you cannot cure it, just like you cannot cure the majority of indolent lymphomas, but it can behave aggressively and grow quickly, just like many of its aggressive counterparts do. So in summary, up until now, we've gone over the basic points of the biology of mantle cell lymphoma. The hallmark is the overexpression of cyclin D1, which leads to constant cell cycling, which explains why it responds to current therapies, but it keeps coming back and it keeps coming back and you can't cure it. Because it's a disease of the immune system, it's almost universally stage 4. And because the cell cycle changes from or differs from person to person, you will see heterogeneity between patients. And that heterogeneity can follow a spectrum. You can have patients with very indolent lymphoma, just like you can have patients with follicular or SLL who don't have rapidly progressive disease, all the way to very aggressive disease. And you can have a whole lot of different presentations in between. Indolent forms of mantle cell lymphoma present with something we call the leukemic non-nodal variant. And the name kind of tells you what it is. Leukemic means that you're seeing white blood cells or an excess of white blood cells. And non-nodal means that it doesn't form big lymph nodes that you can see on a scan or feel on physical examination. So these patients look almost like a patient with very early CLL, where they have an elevated absolute lymphocyte count, perhaps with other subtle abnormalities in blood work, but not much more. Many of these patients can live actually for many years without even needing treatment. So observation is a potential option in mantle cell lymphoma. And then you have the more aggressive end of the spectrum, typically with what we call blastoid or pleomorphic morphology, treatment resistance, and these patients don't tend to live very long. How long is long? Well, so here is a depiction of overall survival in British Columbia. So again, this is our first Kaplan-Meier curve. And what I've done here is looking at survival across eras as we introduce treatments. So in blue, we have the cytotoxic chemotherapy era going all the way back to the 80s and 90s when all we had was chemo. And then we introduced rituximab and transplant in 2003, and we used that for 10 years. And then in the last era, or the current era, we have bendamustine, and we have a number of novel agents. We have BTK inhibitors, we have CAR T-cell therapy. So as we have kind of improved our therapy for mantle cell lymphoma, you can see how the survival curves have improved. Now, are we even close to a horizontal? No. And in this study, what I did was I matched every single patient with mantle cell lymphoma with a general control from the population on the basis of sex and age. And so the dotted curves show you what a normal population is expected to live. And you can see the gap. And I think this is an important point, is that we have a long way to go in terms of improving outcomes for mantle cell lymphoma. But that's kind of across the board. But how do you estimate prognosis for a patient in front of you? Like, what are there any clinical tools that can help you say to a patient, I think it's going to be less than the median, more than the median, a few years, many years? This is probably the most common tool that we use, and it's something called the Mantle Cell Lymphoma International Prognostic Index, or the MIPI. And what it does is it looks at age, performance status, LDH, and white blood cell count, and you can look this online. And you give points to each of these categories, and it can actually calculate the probability of being alive at 5 years. So if you don't have many of these high-risk features, 83% of patients are alive at the 5-year mark. If you have several of these features, only a third of patients is alive at the 5-year mark. So it's helpful when people are asking what you think their survival might be. And so this is an example of what it looks like when kind of in a more graphical way. So you can see in young patients and elderly patients, these kind of 3 categories of the MIPI can help you kind of define a good prognosis group, a bad prognosis group, and sometimes it can also help you with an intermediate prognosis group. So we use this all the time. Now, what about frontline therapy? So first of all, I indicated that not everybody needs to have therapy from the get-go, especially these patients with indolent disease. You can observe those patients with mantle cell lymphoma who you think have or are expected to have an indolent clinical course. And data for that comes from British Columbia. So a few years ago, we looked at our patients with mantle cell lymphoma, and we looked at those who had received early treatment versus those who had been observed for at least 3 months. And in our database, we found that about 17% of patients were observed for at least 3 months. And so if you look at this incidence curve, we're looking at the probability of time to treatment. So here at time equals 0, nobody has been treated. Time goes by and people are going to require treatment. And so you see how the curve begins to go up because all of these people are needing treatment as time goes by. Well, so that kind of shows you a few interesting things. The first one is that at the 1-year mark, about 20% of people have required treatment, but the other 80 can go beyond the 1-year mark. That's helpful clinically. The other question is, where's the median? So at what point does half of your cohort require treatment? And that's at basically at the 3-year mark. So if you select patients, you can say to them, if I observe 100 patients at the 3-year mark, half of them have required treatment, and a small proportion don't require treatment for a very long time, but you can see how almost all patients need treatment at some point sooner or later. Who are the people who do not need treatment or who initiate treatment less often? The ones with leukemic non-nodal disease, and a few who have very limited gastrointestinal involvement. Now, with so many improvements in mantle cell lymphoma, there's always this question, are you potentially hurting patients by not treating them? Like if we have all these great new tools, why aren't we using them? And our study showed that if you look at the survival of observed versus treated patients, the survival of the observed patients is actually better than the survival of patients who required immediate treatment. Well, that just reflects biology. They were observed because they were expected to have a better prognosis in the first place. So these curves are not really a surprise, but they provide reassurance in the sense that the survival of the observed patients is not worse than the survival of the early treatment patients. So again, evidence that you're not hurting your patients by observing them for a period of time before you go in with first-line therapy. But as I have already said a couple of times, almost all patients will require first-line therapy at some point sooner or later. This is the algorithm today in December 2024, and I bet you that this algorithm may change in the next couple of years, but this is the way we do things in Canada today outside of a clinical trial. So today what we do is we assess a patient's age and their comorbidities, and we classify them into the very fit patients who you think you can treat with more aggressive therapies versus patients who are fit for kind of conventional dose therapy. And then there's a category of patients who are not fit for really any form of conventional therapy and whom you're doing kind of the more palliative treatments with dose reductions and all of this. So we'll kind of break this into parts. So the first part is to break this into those who are young, and youngest fuzzy line between 65 and 70, but more importantly, who are fit for intensive therapies. And these patients can be treated with a number of different regimens. The treatment of these young patients basically follows 3 steps. The first step is called induction. In other words, you want to induce a response, and that's done by combining rituximab with chemotherapy. And typically, we give patients 6 rounds to achieve a response. And once you've had a response, you want to really deepen that response. And the traditional way of doing that is to give them a really high dose of chemotherapy, but that needs to be rescued with an autologous stem cell transplant. And remember, that means that you're rescuing them with their own stem cells, and that's what allows you to give them high dose chemotherapy. At the end of that transplant, patients will have had very little residual disease, and you want to maintain that. So you treat them with maintenance rituximab for about 2 or 3 years, and the idea is to lengthen the duration of that response. here we are relying on two kind of therapies with complementary mechanisms of action. We're giving them rituximab, which is a monoclonal antibody, so immunotherapy, and then we're using classic cytotoxic chemotherapy, and these are drugs that interfere with cell cycle and or DNA. And different regimens have been evaluated over the year. I'm showing them on this slide. And so the purpose I'm showing this slide is it's to confuse you a little bit, but also to show you how many different regimens have been used by different groups. So some people have used a regimen called hypercivet. Some people have used regimens where they alternate chemotherapy. Some people use bendamustine regimens. It doesn't matter. The point is that there are a number of different chemotherapy regimens that can be used in this setting. The one that has been used the most is a regimen that I'm sure many of you have seen, where R-CHOP is alternated with R-DHAP. So cycle 1 is R-CHOP, cycle 2 is R-DHAP, cycle 3 is R-CHOP, cycle 4 is R-DHAP, cycle 5 is R-CHOP, cycle 6 is R-DHAP, followed by transplant, followed by maintenance. And the rationale for that came from a very large European study called the MCL Younger study. So that's the one I'm showing here. And here they compared that alternating regimen against just R-CHOP with transplant. And with basically 10 years of follow-up, the blue curve is the alternating regimen. You can see how the median time to treatment failure is about 8 years. Wow, that's pretty impressive for mantle cell lymphoma. If half of your patients are free of treatment failure at the 8-year mark, of course I wish it were longer, but still for mantle cell lymphoma, that's actually pretty good. And with the passage of time, patients might actually live a little bit longer, and that's the OS probability. Now, this regimen is not the easiest regimen. It has significant toxicity, but it can, if it's done in the right hands, I think it can be safely administered. Is this the only way you can treat a young patient with mantle cell lymphoma? No. In British Columbia, we use bendamustine. In British Columbia, we don't use R-CHOP alternating with our DHAP. We use 6 cycles of BR transplant maintenance. So this is a study that I did with the Germans who did the previous study, where we compared our patients in BC receiving BR transplant and maintenance against the patients in the European study receiving the alternating regimen. And you can see how outcomes are similar. So, I think the chemotherapy partner matters to some degree, but I think what really matters here is getting your patient through those 3 steps of treatment. But so far, we've talked about very kind of standard and classic treatments, which are chemotherapy and rituximab, and the world is a lot more complicated than that, and biology is a lot more complicated than that, because rituximab binds to the surface, there's DNA, but there are other receptors in the surface of the molecule. For example, there's the B-cell receptor. So, there's a lot of communication that needs to happen between the surface of the cell and the DNA. And if you look at that in a more pictorial form, you have the cell surface here, you have the nucleus here with the DNA, and you can see this whole complicated cascade of molecules that bring messages from the outside to the inside and tell that B cell what to do. It's complicated, but it's also an opportunity for treatment because you can target basically any of these molecules with a small drug, and you could potentially disrupt those signaling pathways. And that leads to a different category of treatment that's not an antibody, that's not chemotherapy, but some form of targeted therapy. So some of you might be guessing where I'm going with this. So one of the molecules that's very close to the B-cell receptor is a molecule called BTK. And there are drugs that can block this. And the moment you block this, you block the whole downstream signal of the BTK receptor. So these are drugs like ibrutinib, acalabrutinib, and zanubrutinib. So these are oral drugs that if taken continuously can literally shut off a B cell without the side effects that you see with rituximab or without the side effects of chemotherapy. And you can see how it's a totally, totally, totally different way of treating lymphomas. And this is why these drugs have completely changed not just the way we treat mantle cell lymphoma, but the way we treat so many other lymphomas, like CLL and Waldenstrom's, because of this different mechanism of action. Now, these drugs are not exactly interchangeable. And that's because they target BTK, but they also target other kinases. In other words, they're not clean drugs that they just block BTK. Many of these drugs can block other small molecules within the cell. And so these are maps that show the different molecules or kinases that these drugs block. And you can see how ibrutinib blocks a whole bunch and how acalabrutinib is probably the most targeted of them. So this big dot here is BTK. So you can see it here, you can see it here, and you can see how zanubrutinib is kind of in the middle. And that explains the toxicity. So the more off-target molecules that you block, the more side effects that you can expect to see. So with ibrutinib, you see a lot more bleeding, hypertension, atrial fibrillation, arthralgias, GI symptoms, rash and fatigue than what you see with acalabrutinib or zanubrutinib. You still see them with acalabrutinib and zanubrutinib. You just see less of them compared to what you see with ibrutinib. So this is why many of us in Canada and around the world prefer to use acalabrutinib or zanubrutinib because it's just gentler on the system compared to ibrutinib, although your patient can still run into problems. Now, these drugs are effective, especially in the relapse setting. So this is a kind of a summary of ibrutinib, acalabrutinib, and zanubrutinib trials in patients with relapse refractory mantle cell lymphoma. And you can see response rates. You can see overall response rates and complete response rates here. And you can see how there's a bit of a broad range between them. But the bottom line is that these drugs are active on their own. And this is the standard of care in Canada and around the world as second-line therapy of mantle cell lymphoma. Okay, well, if these drugs are active and they have a different mechanism of action and they're safe, then the obvious question is, why are we not using them as part of first-line therapy? I mean, would that not improve first-line therapy if we just kind of throw 3 different drugs with 3 different mechanisms of action? Maybe. And that's where the triangle study comes in. So the same group that did the younger study did a study evaluating what happens when you add ibrutinib to that kind of chemoimmunotherapy backbone. And so the triangle study had 3 arms, hence the name triangle. The first arm, or arm A, was the standard arm. So what we already discussed, the alternating chemo, the transplant, the rituximab maintenance. The second arm was the exact same platform, adding ibrutinib. So they're adding ibrutinib with the chemo, they stop it for the transplant, and then they add 2 years of maintenance. And the last arm, which everybody, myself included, thinks is the most interesting one, uses ibrutinib with the chemotherapy, avoids the transplant or skips the transplant altogether and moves straight into maintenance. And the hypothesis here is that when you're using such an active drug like ibrutinib, the benefit of the transplant is completely abrogated because the ibrutinib basically makes up for whatever benefit the transplant brings about. And this is basically what the study showed. So here I'm showing again failure-free survival and on the left and overall survival on the right. And the green and the gray curves are the ibrutinib arms. And you can see how the ibrutinib arms are traveling on top of each other. And the non-ibrutinib arm, so the standard arm, is a little bit lower, both for overall survival and failure-free survival. So what this means is you can actually improve outcomes with first-line ibrutinib plus chemotherapy, and that for the majority, if not all, of your patients, transplant is no longer necessary if you're using ibrutinib as part of their frontline chemoimmunotherapy. This is huge. Patients don't like to have a transplant. Doctors don't like to send patients for transplant because of the short and long-term toxicities of transplant. So this is a massive quality of life improvement for our patients if we can avoid all of the problems that come from a transplant and treat them with all of these drugs in the outpatient setting without all of those issues. So I think this is a win, and everybody around the world wants to get their hands on first-line BTK inhibitors. Remember, you have to use them with chemotherapy if you want to get these results. But the problem is that these drugs are not available as part of the public healthcare system because the public healthcare system provides them as second-line therapy. So today we have a gap where it's tricky to get access to first-line BTK inhibitors, to do this type of therapy. It's not impossible. There are ways one can get access to these drugs, but the system does not provide. Now, one way you could access these drugs is on a clinical trial. So this is a study that's a Canadian study that I am running together with one of my colleagues from Princess Margaret, and it's the Osmosis 109 trial. We call it the rectangle trial. And here what we're doing is we're giving patients R-CHOP with acalabrutinib transplant, and then we do maintenance with rituximab and acalabrutinib for 2 years. This study accrued already. The study accrued in May of last year. We accrued 54 patients from Vancouver, Sunnybrook, Princess Margaret, Quebec City, and Halifax. And these patients have all completed their initial treatments. A few of them have already completed the whole package, and we still have a few on maintenance. And so this will be an interesting way to compare our Canadian outcomes to what was seen in Triangle. We are about to open the study again to a cohort of 51 patients in the same centers without transplant. And so I think this is a good example of how we are able to access novel therapies in Canada when they're not quite yet available through the healthcare system. And so I would encourage everybody who's listening to this to think about this study, because this could be an option for your patients who need treatment for mantle cell lymphoma. And we are, of course, more than happy to see those patients for this study. So that's the summary of treatment for younger patients. So outside of a clinical trial or outside of a situation where you can access a BTK inhibitor, this is the pathway to follow when you're using chemotherapy and rituximab. Well, going back then to the algorithm, what about the right side of the algorithm? What do you do with patients who cannot tolerate the R-CHOP or DHAP, or who cannot tolerate a transplant? How do you treat those? Well, similar idea. You don't treat them with a transplant. You treat them with induction. You're going to modify the chemotherapy partner, and you're going to treat them with maintenance. So it's a slightly more abbreviated package, although it still ends up being a 2.5-year package. But basically, you modulate your chemotherapy and you reduce the transplant. What chemotherapies can you use for these patients? Well, there are different options, and just like I did with the younger patients, there's a number of different studies that have been done over the years. So what's kind of the gist of these studies? Well, the gist of these studies is that regimens such as bendamustine, rituximab, or R-CHOP are the way to go. So these are data from British Columbia, where we looked at our experience treating patients with bendamustine, rituximab, versus R-CHOP, so 2 eras, an era of BR, which is the current era, versus the previous era 12 years ago with R-CHOP. And you can see how we broke it up by age. And you can see how survival, this is overall survival, has actually improved in our population with the use of bendamustine rituximab, both in the young patients shown in blue and red, as well as the not so young patients in green and purple. So I think this is why most of us use BR, definitely for the elderly patients, and in BC across the board. This has been shown by other groups. So this is a large American study looking at R-CHOP with maintenance versus BR with maintenance or without maintenance. And you can see how this is time to next treatment, and this is overall survival. And the red curve is bendamustine rituximab with maintenance. You see kind of how it's the winner in terms of reducing or delaying time to next treatment, and in terms of kind of an overall survival benefit together with R-CHOP and maintenance. But the world has moved on. And just like I showed you the triangle study, a number of studies are also evaluating BTK inhibitors in the frontline setting. So these are the 2 studies that are most similar to each other, and perhaps some of you have heard of them. One is called the ECHO trial. So the ECHO trial combined bendamustine rituximab and maintenance with acalabrutinib, and SHINE combined ibrutinib with the same backbone of BR and maintenance rituximab, and compared those 2, BR and maintenance without the BTK inhibitor. And both studies show kind of the same thing. This is progression-free survival. And both studies show that progression-free survival is improved when you add a BTK inhibitor. And it's improved by about 10% at the 5-year mark. So you're not curing anyone, but you're definitely improving survival, progression-free survival, not overall survival, for a proportion of patients. The catch here is that the drug was given continuously until progression or toxicity. So unlike triangle and rectangle, where the rituximab is cut at the 2-year point of maintenance, here it goes on until progression or toxicity. So, the median PFS, for example, is 66 months. So what that tells you is that patients were taking ibrutinib, or half of the patients were taking acalabrutinib or ibrutinib all the way through, beyond the 5-6 year mark. So it's something to think about, because then there's issues around exposure, there's issues around cost, and there's issues around toxicities, many of which can develop as time goes by. But nonetheless, that's the benefit seen with frontline BTK inhibitors in this subgroup of patients. Now, these two studies were done with bendamustine, rituximab, and the BTK inhibitor, and you could argue that this is a little bit tough for many of the older patients. And so it begs the question, can you get away without chemotherapy? Could you do just the BTK inhibitor and the antibody? I mean, this is something that patients ask me all the time. Why do I have to get chemo? Can I get away with my pills and rituximab and see where that gets me? And for many years, we didn't know the answer. We just heard about the ENRICH trial earlier this month from the British group, and this study provides information that I think is very helpful. So what they did in this study is they took 400 patients over the age of 60 who were not eligible for transplant, and they were randomized in orange to either R-CHOP or BR with maintenance versus ibrutinib with rituximab. And again, the ibrutinib was continued until progression or toxicity. And what they found was an improvement in progression-free survival with the BTK inhibitor arm. In other words, you can improve, or you can reduce the risk of progression or death with the ibrutinib rituximab strategy. So patients obviously love this. Now, they had 2 different chemos, and so when you compare this to that benefit appeared to be restricted to the comparison with R-CHOP, and at the end of the day, outcomes appear to be identical with BR, and there was no difference in survival. So let me translate that. If you use ibrutinib rituximab with the ibrutinib until progression and toxicity, it is going to get you more or less to the same place than our standard of BR and maintenance rituximab does. Again, this is huge for patients, but remember, the catch is that you have to take it on a continuous basis, which potentially increases the toxicity of long-term ibrutinib exposure, but you could argue avoids the toxicity of chemotherapy. And it might get you to an even better place than if you were to treat that patient with R-CHOP. So I think it'll be very interesting to see if we can get this type of therapy in the Canadian setting. So this is the summary of treatment for the younger patients, or for all patients with mantle cell lymphoma. Again, today, because BTK inhibitors are not approved for just kind of widespread use as first-line therapy in the public healthcare system, our current standard is chemotherapy with rituximab, but I remain very optimistic that we will be able to have easier access to these agents in combination with rituximab plus or minus chemotherapy as time goes by. So then moving on to treatment for relapsed refractory mantle cell lymphoma. There are a lot of options that one can use here. And there is no single standard of care. There's a lot of options that one can use here. And the good news is they keep expanding. And I think there's a lot of hope for patients that really the last 5 years, we've seen an explosion of options. And many of these options are slowly making their way to our clinics. We think more of them will. And there's a lot of active research in many of these agents. And there might be a center close to you, or even a center where you work, where there might be clinical trials that, again, provide access to these drugs, because many of these drugs are not available to our patients either. But this is kind of a list of kind of what goes through my mind when I'm seeing a patient for second, third line or beyond lines of therapy. You can treat them with chemotherapy and rituximab, although nobody really does that anymore. I think most of us are more interested in novel agents. And we'll talk about a few of these. You can do radiotherapy. We rarely use allogeneic stem cell transplant these days because we now have access to CAR T-cell therapy in Canada. So I think this is kind of the list of options that we use for relapse refractory mantle cell lymphoma. So if your patient did not receive a BTK inhibitor as part of first-line therapy, then most of us are going to move to BTK inhibitors, and these are your options. And I already talked about the differences between the three agents and why we prefer acalabrutinib or zanubrutinib over ibrutinib. And we already talked about the expected response rates and duration of PFS with these agents. Remember that the side effects of these drugs, while less common for acalabrutinib and zanubrutinib, they're not zero. And some of these patients need to switch from one to the other because of toxicity, and sometimes a switch from one to the other may get you to a better place. This another kind of important point, which is if you're going to use a BTK inhibitor, you really should use it early on. So this is a study looking at the use of ibrutinib in different lines of therapy. So in blue, you have the use of ibrutinib after one line of therapy, in other words, a second line therapy. In orange, you have after 2 lines of therapy, so third line therapy. And in kind of this dotted line is kind of beyond. So you can see how PFS and OS are improved when it's used second line. So most of us don't even bother with recycling chemotherapy, even if they've had a median progression-free survival of 8 years, as shown in the triangle study. Most of us prefer to just move on to second-line BTK inhibitor monotherapy because of these results. And that's great. But the problem is that these drugs are not curative, and you expect patients to develop resistance mutations to BTK inhibitors at some point sooner or later. And the moment you see that, there's a change in the biology of the mantle cell lymphoma. It's like stepping on the gas. Things really pick up when people become resistant to BTK inhibitors, and many patients die. So this is kind of another sad reality, kind of like with a success comes a new challenge. So these are different studies looking at overall survival after people discontinue BTK inhibitors. You can see how in an American study, the overall survival is less than 6 months. In an Australian study, it's about 7 months. And in another American study, it's about 6 months. So this is the problem. BTKI resistance is associated with poor prognosis. So this is an area where there's really a high need for additional therapies. Either there's a need for such therapies. Another question would be, can you add something to the BTK inhibitor? In other words, is there a second agent that you can add on top of it that allows you to stretch the duration of the benefit of your BTK inhibitor? And that's where venetoclax comes in. So many of you may have heard about venetoclax. It's a drug that inhibits a different molecule called BCL2. We've used venetoclax in chronic lymphocytic leukemia for a number of years. Now it's an oral agent, just like BTK inhibitors. And yes, the ramp up to reduce the risk of tumor lysis syndrome is a little bit cumbersome, but for the most part, it's a drug that's very well tolerated and with a mechanism of action that's kind of complementary to the mechanism of action of BTK inhibitors. So it makes perfect sense to combine these two novel agents together and kind of see what happens. So this is a study called Simpatico. And Simpatico looked at patients with relapsed mantle cell lymphoma who needed to go on ibrutinib or zanubrutinib or acalabrutinib. And those patients were randomized to ibrutinib with venetoclax versus ibrutinib plus placebo. So basically what we would do. And they were followed. And so they enrolled 267 patients. Half got the combination, the other half just got the ibrutinib. They followed them over time. And you can see how the patients who got the combination of ibrutinib and venetoclax had better PFS than the ones that got ibrutinib and placebo. And you can see how that kind of 50% or median PFS was improved by about 10-ish months. Hey, not bad that a patient in the relapse setting is able to squeeze almost an extra year by being on dual therapy. I think most of us would consider kind of significant. So, you're not benefiting 100% of your patients with this approach, but I think the ones who benefit certainly enjoy longer um, uh, duration of disease control with the dual therapy. So this is something we might see in Canada in the future, although this therapy is not available today. What we do have in Canada is CAR T cell therapy or chimeric antigen receptor T cell therapy. We have this therapy available pretty much across the board for a number of lymphomas, including aggressive lymphomas and mantle cell lymphoma. So as a reminder, this therapy is very complicated. This is an immune therapy. Hey, we haven't talked about kind of immune therapies in this sense up until now. So this is yet another novel therapy with a completely different mechanism of action. So what's done here is you do a procedure called a leukapheresis, and the name tells you what it is. Leuk means white, and apheresis means removal. So patients' white blood cells are removed, similar to what's done when you're collecting stem cells prior to a transplant. Those cells are then shipped to a lab, and those cells are genetically modified to express a specific receptor on their surface that not only identifies B cells better, but when they do, those cells are supercharged to just go in and kill that B cell. So once that product is done and once they're happy with a kind of a good population of T cells, they get expanded, they get shipped back to the hospital, given to the patients. So totally different mechanism of action. The study that put CAR T cell on the map was a study called ZUMA-2. And here they took 68 patients with relapsed refractory mantle cell lymphoma. And you can see here in the table of baseline characteristics, I like to show this. 100% of these patients had received a previous BTK inhibitor. And you can kind of see that 62 were refractory, 26 had relapsed, patients had received a whole bunch of other treatments, and these patients are destined to do poorly. So they went on and they got their CAR T cell therapy, and yes, there was toxicity, and yes, there was CRS, and yes, there was ICANS, and yes, there were infections. But look at the 3-year follow-up and look at the response rate. So 91% of patients responded and 68% had a complete response. So this is a good number to keep in the back of your head. And this is something I say to patients all the time. 2 in 3 patients have a complete response. There is no other therapy in relapsed refractory mantle cell lymphoma that gives you this type of mileage. And if you look at the blue curve here, which is the patients with a complete response, orange is with both, and red is with a partial response. This is duration of response. So you can see how at the 3-year mark, for example, a quarter of patients are still in a complete response. Yes, there are progressions down the road, but this is quite impressive that with a one-time treatment, albeit a complicated treatment, many patients can enjoy a very long period of disease control without requiring any other therapies. Now, is CAR T cell curable or curative in mantle cell lymphoma? We don't know. We think CAR T cell therapy is curative in aggressive lymphomas. It probably is curative in mantle cell lymphoma for a proportion of patients. But we need longer follow-up from ZUMA and a number of other studies to see if that really is true. Because these drugs are so novel and these patients have not been followed for long enough that we just need more time to see if their lymphomas are going to come back or not before we can declare that these are curative. And if we do declare that these treatments are curative, then obviously we're going to, as a community, push really hard to access these drugs much earlier in the course of disease, because today nothing is curative in mantle cell lymphoma. You could argue that the occasional patient gets cured with an allogeneic stem cell transplant. You could argue that the occasional patient gets cured with an autologous transplant or intensive chemo, but by and large, it's not curative. But today we push hard to get our patients into CAR T when they're eligible because of this potential for long-term disease control. What else is out there? Well, we also have non-covalent BTK inhibitors. So some of you have heard about a drug called pirtobrutinib. So pirtobrutinib rhymes with ibrutinib and acalabrutinib, but the difference is that it binds to the BTK in a non-covalent way. I will explain what that means in a moment. there are a few interesting things that make pirtobrutinib stand out and that really separate it from the other three that we have talked about. The first one is that it's very selective. So this is a kinome map similar to the one that I showed you for the other ones. And you can see how there's a single red dot. That tells you that it just goes for the money. It goes for BTK with very little inhibition of those other kinases. So what that means is that you see very little toxicity with pirtobrutinib. It's not like you see zero, but you see a lot less than what you see with the other. The other thing that I find very interesting about pirtobrutinib is the way it binds to BTK and the way it blocks BTK. So this is a picture of a protein target. So the black is BTK. And this orange drug is your ibrutinib. And it's interesting, ibrutinib kind of fits, it kind of attaches to the BTK, but what's fascinating is it attaches to one amino acid of BTK. That's it. It attaches to a cysteine 481 amino acid. That's it. There is literally nothing going on. There is literally nothing going on here. So even though they're kind of touching each other, there is nothing going on there. All the action is occurring via this one amino acid. So all the BTK has to do is mutate that amino acid, and you have a resistance mutation. Pirtobrutinib is different. It does the same thing. It kind of locks itself into the BTK, but notice how it doesn't bind to that one amino acid. What it does is that through a number of non-covalent bonding, so ionic bonds or van der Waals forces and all of these kind of other phenomena that I'm sure you don't remember from high school chemistry, there is an interaction. There is an interaction of forces that occurs all the way through. So the BTK can inhibit that cysteine amino acid if it feels like it, but the inhibition will still take place. And as long as you're taking the drug will kind of inhibit that molecule one way or another. Well, that's very interesting because then that suggests that if you have a patient with a resistance to ibrutinib or acalabrutinib, you might be able to overcome that by using a non-covalent BTK inhibitor. And that's what was shown in the clinical trial. So here you have 90 patients who had received a whole bunch of treatments, and they got pirtobrutinib. Now, the response rates don't seem very high compared to some of the response rates and CR rates that I've shown you so far. But this, I think, is important, is the color of the bars. So this is called a waterfall plot. And what this is showing is response. So if you read the y-axis here, it's the change in the dimensions of those lymph nodes. And if you can get things to shrink, then the dimensions decline. If things grow, the dimensions go up. And if things shrink less than 50%, then that's a partial or a complete response. That's the overall response rate. So 58% of patients were able to shrink their disease to a partial or a complete response. And the blue bars are the ones that had discontinued covalent BTK inhibitors. So they had been previously treated with ibrutinib, acalabrutinib, or zanubrutinib, and had developed progressive disease, and you can see how they respond. Not everybody responds. I get that. But the point is, a number of patients with resistance mutations still do. So to me, that's proof of principle that the mechanism actually works in the real world. And this is a drug that we absolutely want to get our hands on because this provides a standalone line of therapy for our patients with mantle cell lymphoma. Now, is it better than ibrutinib or zanubrutinib? I don't know. That's being evaluated in a clinical trial that was open actually in Canada, comparing pirtobrutinib head-to-head with the 3 covalent BTK inhibitors. And all of us are waiting for this study to tell us how they perform compared to each other. And this could easily change the way we treat mantle cell lymphoma. But for this one, we'll have to see. So this is a summary of the agents that we use in relapsed refractory mantle cell lymphoma. There are others, but I didn't want to go into those because I wanted to highlight the ones that are either approved or the closest to being approved, as these are the ones that patients ask about all the time. So to conclude, mantle cell lymphoma is a heterogeneous disease today. Rituximab-based chemotherapy remains the initial first-line standard of care with or without transplant. BTK inhibitors are the most frequent second-line therapy. We use them as monotherapy, but I showed you triangle and rectangle and shine and echo and all enrich and all of these studies where these agents are quickly moving into the frontline setting. And I think as a mantle cell community, we want to see these drugs being used in the frontline therapy. There are several new agents with different mechanisms of action with activity in mantle cell lymphoma. And I think the future is hopeful and bright in the sense that as we have more and more of these, we'll be able to run more combination studies. And I think we will end up with a good problem of having a whole bunch of options and figuring out the sequence and the combination. And that's a good thing because this is how you find cure. The stark reality is that in 2024, despite all of these advances, mantle cell lymphoma remains incurable. But that doesn't mean we should give up. And I think we just need to keep doing the research and enroll patients in clinical trials because this is the way we'll be able to improve outcomes for our patients with mantle cell lymphoma. So thank you very much to all of you who joined this webinar, and I look forward to being able to join again.
Thank you so much, Dr. Villa, for this presentation. And to you who are listening to us, I hope you enjoyed it as well. We invite you to access the continuing education platform to view our other training courses. And this event was made possible thanks to the support of AbbVie and AstraZeneca. And finally, I'd like to remind everyone that we are here for the blood cancer community. Please do not hesitate to order our tear pad for free and contact us if you need more information or support. We hope you have a wonderful rest of your day. Thank you.